They had worked with the caucus for the boys. Okay, no imitations, please. All right, good afternoon, everybody. Let's call this meeting of the Health and Human Services Committee to be in play. Gee, we must not count, or there's 50 other meetings going on. We usually have a full house. So welcome to y'all that thought health was the most important one. So with that, Chairman Unterman, let's go ahead and do Senate wait a minute. Are they both Senate bills? No. Which one's a resolution? They got them? Okay, Senate Resolution 981. Let's do that one first.
Okay, thank you very much, Mr. Chairman. This Senate Resolution 981, I believe it passed unanimously in the Senate, and it's the Study Committee on the Violence Against Healthcare Workers. This past summer, last year, we did a tour around the state of Georgia, and the recurrent theme has been, unfortunately, healthcare workers who have people accost them and do things to them while they're trying to perform their duties, not only in the emergency room, but even in the lobbies of big hospital systems. And the purpose of this is to study what we could potentially do to help them. I have some confiscated weapons at one particular hospital in northeast Georgia. They have literally kept barrels where they put the weapons in, and they took me and showed me the weapons, and I asked them to make some photos of the weapons that have been confiscated. And I know from working in the emergency room how difficult it is when you're trying to help people, but unfortunately you get involved with people who come with other people, whether it's gang activity related or not. And you know, it's a sad situation when you're trying to help people and you have other people harming you while you're trying to help someone. This study committee will have representatives from the hospital on it. It will have 3 members from the House appointed by the Speaker and 3 members from the Senate. And hopefully we can come up with some recommendations. I'm going to pass these photos around. And I'd like to have them back. Photos. Real expensive photos. They're
Wow.
made on really nice papers. Can you pass those in the back?
Thank you, Senator.
One of the most egregious things I've ever seen as an emergency room worker was a carpet knife. And a carpet knife is a knife that's very inexpensive, and you can buy it at Home Depot. And you can buy it anywhere at any hardware store. But it has a carved hook on it, and I'm not sure if it's in one of those. But you can use it very easily to zigzag on skin like this. And some of the worst wounds I've ever seen a plastic surgeon have to sew up have been a very expensive weapon, inexpensive weapon. And, you know, that's some of the issues that we need to be looking at when we do this study committee. I'll be glad to answer any questions.
Okay.
If you look at those weapons, it goes all the way from guns to screwdrivers to hammers to switchblades.
Okay, questions from the committee. Representative Dempsey.
Yes, mine is not a question but a comment. I also was at that hospital. The Mental Health Access Study Committee also went there.
Right.
And this came up as a strong concern, and in our recommendations from our joint committee report, the challenges that are being met, particularly in the mental health arena, when people are not able to think quite as clearly and panic.
And that's one of the issues that's changed with emergency rooms, because we are a point of access now in emergency rooms, having behavioral health beds and crisis intervention. And that's one of the things in the last couple of years that's completely changed, that hospitals did not have to deal with as much. Most of those rooms are on video cameras, and because of suicide watches and things like that. But this is a new issue.
Well, I want to thank you and tell you that I'll be glad to do anything to help to make sure that those who are there working and visiting in our hospitals are safe.
Right.
Okay. Representative Rogers.
Yeah, Senator Utterman, I was just reading through the bill, or resolution, I should say. Can you explain to me on lines 40 and 42 what that means?
Let me get my bearings here.
Okay. You're not, I guess, a question, you're not asking the state to fund.
No.
Okay.
I think it's for state employees. This past summer we had a problem with our study committees with state employees being reimbursed, and I think it was put in there because of that. I know that I personally paid out of my own account for state employees to go with me to Valdosta.
So this will still,
I believe this will reimburse them for their transportation.
for the state employees?
This is for state employees.
Okay.
Yeah.
Thank you.
Okay. Any other questions from the committee? Okay. We have two people that want to speak on the bill. Okay. Deb Bailey.
Madam Chair, members of the committee, thank you very much. And my name is Deb Bailey, and I represent the Northeast Georgia Health System in Gainesville. We are a 560-bed community not-for-profit hospital, the second busiest emergency room in the state now, with over 100,000 visits. And the pictures that you have in front of you are from my hospital over the last about 2 years, I think. Well, actually probably have more since then. But with that, we now have 475 times this last year called security on issues to address some type of assault on our healthcare workers in the emergency room. And 37 times the staff were actually assaulted in some form or fashion. We actually now have more security in our hospital than they have in the county that's adjacent to us in White County. We have more on staff. So this has become a very big issue for us, particularly as the psychiatric hospitals have closed, and we do find more and more psychiatric patients in our hospital, and particularly in our emergency room. And if you think of 100,000 visits, and you know in the South, when someone comes to the hospital, they like to bring their family with them. So that's hundreds of thousands of people in our emergency room on an annual basis. And we felt like that a study committee would help us to look at what the issues are. We do not have the answers, but if we could bring the experts across the state and look at this, then maybe we could come up with some resolutions for this. We're losing staff over this. People are choosing not to work in these areas, and it's a huge concern. So I would ask for your favorable support of Senate Resolution 981. Thank you.
Julie Wyndham.
Thank you, Madam Chair, members of the committee. My name is Julie Wyndham. I represent Stratus Healthcare as well as the Medical Center in Macon. In addition to being the state's second largest hospital, we have 6,000 employees, including 590 medical staff, a Level 1 trauma center, a Level 3 NICU, 103 residents, all focused on primary care, and a state-sworn police force of 29 full-time employees to patrol our campus. Due to the recent increase in violent calls received from the ER, we now have 2 full-time police officers stationed in our ER at all times. During 2012, there were 4,312 violent calls in the ER and 4,481 in 2013. This includes not only physical abuse, but also threats of abuse against our workers. That's an average of 11 calls per day in our ER alone. The causes, as has been mentioned, are a tense situation with family members worried about their loved ones, substance abuse, gang activity, and psychiatric patients. The consequences are harm to our workforce, our patients, and our visitors, decreased productivity due to injuries to workers, and precious resources being diverted away from patient care to public safety. Now, we've been asked what we would like the probable outcome of this study committee to be. We really don't know at this point. Other states have implemented an aggravated assault charge against someone who assaults a healthcare worker, much like we have in this state for police officers. However, we don't think that is the answer, given the fact that a lot of these patients are psychiatric patients and probably would be incapable of forming the intent needed to convict them of aggravated assault. Therefore, we think we need to look at the issue and decide the best way for the state to go. I appreciate your time hearing this issue. I'd like to thank the sponsor for all the work she's done on this, and would ask for your favorable consideration of the Senate Resolution 981. Thank you, Madam Chair.
Thank you very much. Okay. Representative Clark.
Thank you, Madam Chair. To my Senator Renee Unterman, thank you for bringing this resolution. And I just wanted to say that I was really impressed upon me when Deb Bailey gave me a tour of Northeast Georgia and showed me that almost like a bucket of knives. And is that where those pictures came from that very collection? But just absolutely blew me away, and definitely concerned me to think that I have a sister-in-law that works over there, think the danger they're in every day. So I would certainly at the appropriate time would love to make a motion. Thank you.
Representative Reinders.
Thank you, Madam Chairman, and thank you, Senator, for bringing this legislation. Line 40, additional days are authorized. Who would make that authorization?
I'm not sure if it's administrative affairs. Usually in the Senate, if we have additional days, we go and ask the Lieutenant Governor for additional days. But I think this one is 5.
Yes, ma'am. It says not more than 5 days unless additional days are authorized.
Yeah,
I'm always a little nervous about having open-ended resolutions on committee days. Is there something that you feel would be reasonable in terms of capping it?
Well, I'd hate to make an amendment on this because then it'll send it back to conference committee. It may not get out.
All right. Then you know what, given your outstanding reputation.
Oh, I can assure you it won't be more than 5.
Thank you.
Thank you.
Thank you, Madam Chair.
Thank you.
Thank you. Okay. What's the pleasure of the committee? All right. You ready? Josh, go ahead.
I'd like to make a motion to pass this resolution.
Okay. Okay. I have a do pass and a second. Any other further discussion? Okay. Everybody in favor say aye. Aye. Everybody opposed say no. Looks like the ayes have it. Okay, Senator, trying to get you over to your meeting.
Okay, thank you. Senate Bill 352 is a bill that increases the education of Georgians about the disease process of lupus, and it creates the Georgia Council on Lupus Education and Awareness. As you know, and many of us down here have worked for a lot of years on the issue of lupus and know that it is an autoimmune disease, and like other disease processes that becomes debilitating, it lasts over years and years and years, and it's a slow process in some people, and economically, socially, your families, the impact is tremendous on the individual. We had Lupus Awareness Day here a couple of weeks ago, and we had a gentleman that started out as I believe he was a Superior Court judge, I'm not sure, but he was in the Fulton County judicial system, and he had debilitated so much that he's no longer working. And it often affects, it's non-discriminatory, and it affects young people, older people, and it's a terrible disease process to have to live through, very painful. So this bill creates the Lupus Education and Awareness. It's composed of the Commissioner of Health or the Commissioner's designee, 3 members appointed by the Governor, including 1 physician who treats patients with lupus, 1 lupus patient, 1 member appointed by the Speaker, and 1 member appointed by the Lieutenant Governor. The duties of the council include initially investigating the level of education concerning lupus in Georgia, and that's to be posted on a website. And I can tell you from going around the state and talking with people, people are not as aware of lupus, and oftentimes they don't get diagnosed easily and initially, and that's part of the problem. They kind of get bounced around from subspecialist and an indifferential diagnosis. Developing information on lupus endorsed by government agencies, also to be posted on the website, and developing a directory of lupus-related healthcare services. And I think that's what would be most beneficial for families to get them into a point of access of care. I'll be glad to answer any question. I know the Lupus Association is here, and I would probably like to speak to you
Right, we
briefly.
have Kim Schofield.
Yes.
Good afternoon, Madam Chair and members of the committee. I'm Kim Schofield, representative of the Lupus Foundation Georgia chapter. I'm here to ask you to create the council because not only will it help 60,000 Georgians living with lupus, we know that this disease is one that is not recognized. We know that there are many impacted and affected by this, and we've remained silent for too long. Creating this council will not only help us understand in the medical field, but families as well. I get too many calls of people that don't understand because they're constantly told that you don't look sick. And if you can't put an understanding on the disease, then how can we validate it? So I stand before you as one that lives with lupus, that came down here 7 years ago because I got tired of people telling me you don't look sick. And I do look good, don't I? And so I'm here to take lupus from a whisper to a shout. And I just ask you, and I thank so much the sponsoring senator for her hard work and effort on getting this resolved. So we're asking you to pass Senate Resolution 352.
Okay. Anyone else? Okay. All right. Are there any questions from the committee? Pardon? Okay, I think there's no questions. Representative Randall.
Madam Chair, I move do pass Senate Bill 352.
Okay, I have a do pass in a second. Is there any further discussion? Okay, hearing no further discussion. Everybody in favor? Sorry, Representative Reinders.
Thank you, Madam Chair, and thank you again, Senator, for this. This committee has before seen legislation where it says phrases like subject to appropriations, where we've been burned on more than one occasion on that. So I'm very thankful that on line 57 you also have included or access to other private or public funds. That way we don't take the hit that we've taken on some other things for that, and I just think that's nice legislative writing on your part, Senator. Thank you.
Thank you.
Thank you for
And
pointing
the
that out.
Lupus Association has been fabulous. Fabulous.
So thank you, Representative Reinders, for pointing that out. So we have a do pass in a second. Any further discussion? Okay, everybody in favor say aye. Aye. Everybody opposed, no. The ayes have it. Thank you, Senator.
Thank you very much.
You're right on the dot. You may have to fly across the
I know,
street, but
I know.
thank you.
And
See you in a
I'll
little while.
text you.
Okay.
Thank you very much.
Okay, let's see. Okay, Senator Balfour. This is Senate Bill 358, or 391, sorry.
Madam Chairman, committee, Senate Bill 391 is a bill that I came forward with about an insurance product called TRICARE, which is military insurance, whether that's for veterans or retired veterans or people in the military today. The unfortunate thing is a lot of the problem with TRICARE is the federal funding, which is about 50 cents on the dollar compared to Medicare. It's a sad thing that we're that low, but that's a problem that we have on the federal side. This bill suggests that the hospitals make a good faith application to the Southern Regional TRICARE Management Support Contractors for certification for TRICARE. I've spent some time working with the hospitals to make sure this isn't an undue mandate or require them to jump through too many hoops, but for our veterans and our soldiers, I think anything we can do to help them out, the better off we are. Quite often, if you live in Columbus, Columbus Hospital is under TRICARE because they have to be, because the military base is right there. But then they end up really getting soaked because they have to come under Humana insurance, and so if you're by a military base, you have to take it almost by definition, and then you really get soaked because you don't get enough money. If you don't take TRICARE and you're veteran or you're a retired military living in Adel, Georgia, you need to drive to Atlanta to the VA hospital to get taken care of there. And if all the care is at the VA hospitals, the supply and demand just means not that the folks there aren't trying to do a good job. I'm sure they're trying to do as well as they can, but if everyone had to go to Northside Hospital, the supply and demand would mean it would be hard to get taken care of. And I've seen many an instance of veterans that have problems with that, so that's the purpose of the bill.
Okay, questions for the Senator, and I guess I'll start one off. Senator, my husband had TRICARE for life. Is that different from TRICARE?
There are different parts to TRICARE, and depending on, they're all under the same umbrella, but there's 2 or 3 different types of TRICARE depending on how much you're paying into it and so forth. So they would all be under the same thing.
Because I will say that the hospitals in Atlanta, and it was a fabulous payer, and I'm not denying you. I'm just wondering if we're having a special problems with a special kind, and it's hitting our veterans. Tom was reserve, and so I just wonder if we're having more trouble with our actual veterans and the kind that they carry.
We're hearing from veterans all over the state that and it's not a problem. It's not caused by the hospitals, but if hospitals aren't under TRICARE, because if they're under TRICARE, what Humana pays them is literally half of what Medicare makes. So a lot of hospitals don't go under it, and the only ones that really do go on, I say the only ones, that's not true, but most of the ones that go on or under it would be in Savannah or Columbus, where the military bases are, and they end up being soaked anyhow because they're getting such low reimbursements.
I think it's terrible the way we treat our veterans in many instances for many things. Other questions from the committee? I think there must be a lot of people in this committee that feel the same way I do about veterans, and we should show them more appreciation. We have one person that wants to speak on the bill, Tim Kibler.
Thank you, Madam Chair. Tim Kibler was joined the last community hospitals for a 65 hospital association of mostly Georgia's public hospitals. Commend this bill. Thank Senator Balfour for his good work to make it work for our hospital community, and would recommend it for your passage. Thank you very much.
Thank you. Representative Hawkins, think of something?
Yeah, I just got a question. How is this going to address the low payment? Is this going to be able to move the ball down the field in some way?
No.
Frankly, I don't know if that's to me or Senator Balfour. I think, frankly, the answer to that is no, but the hospitals want to support him in his effort, and we hope eventually we'll get down the road.
That's what your head going up and down.
Yeah, it's a good point, and I think long-term, groups like NCSL or CSG or ALEC or just different organizations need to lobby the Pentagon to pay our, these folks are earning, I obviously have a soldier who's sitting in Mozar Sharif, Afghanistan as we speak, but he's just one of many.
Right.
And they're putting their lives on the line. They're picking up arms, whether we agree with what's Afghanistan or Iraq or whatever else. They're doing their duty. They're putting their lives on the line, and we ought to. Now, and this doesn't take care of that reimbursement. But my thought is, if more and more states do this, maybe we can get these national organizations to help lobby for our congressmen, Republican and Democrat, to pay an adequate amount.
Right. To the comment of the chair, TRICARE for Life does not pay for custodial care. It falls short in a lot of areas. There are some pickups under Medicare for surviving spouses and spouses that are not military. I commend you for bringing this, Senator, because there's some real problems with the TRICARE that we did not have as a dentist that have always seen veterans, and I've never charged a veteran anything additional to what was paid by the Veterans Administration. I've seen the change in 40 years of the system work great under Champus. That's what we had.
That's right.
To this TRICARE is a mess.
Okay. Representative Reinders.
Thank you. Just a couple quick clarification questions, Senator, and thank you so much for this legislation. Line 17 for disqualification. Is that something that they will tell them immediately that this is why you you don't get it, you're disqualified for this reason? Is that something that they tell them? Is the medical facility told you're disqualified for this particular reason or these particular reasons?
Yes, they would be going, when they go through the certification process, TRICARE would tell them. Well,
Okay.
Yes, sir.
Thank you.
I was just trying to read it to make sure I
I
got it.
understand. And then additionally, if I may, on line 21 and 22, the commissioner shall maintain files. That's, I don't know what that means, and monitor. I want to make sure for record purposes we have legislative intent. I'm assuming the reason is because we want everyone to know that we've got a mindful eye or careful watch to ensure that facilities are doing the best that they can for our veterans.
That's correct.
But it is a hair vague. What do you actually hope with that kind of language? What are you looking for?
Well, the commissioner would, again, maintain the records from each of the medical facilities in the state to see if they've tried to go through the certification application process for TRICARE.
If the gentleman would go further than if they don't?
Many of them do. Many of them do.
It's a little velvet glove to me, just a little velvet hammer there. Is that the intent?
Many of them do. Many of them, like our dentist friend talking earlier, many of people, maybe they don't take TRICARE, but they write off the cost. I mean, they could literally just say, you're a veteran, I'm going to take care of you, and we're going to write off the cost. But
I just don't want a commissioner to hold up a file and say, here's my file next.
Right.
And, not have any teeth or substance or whatever. But thank you so much.
Thank you.
Lucas? Okay, thank you. Any other questions from the committee? Okay, okay. Ready for a motion? Okay, we have move to pass Senate Bill 391. And a second. Is there any further discussion? Okay. Everyone in favor say aye. Aye. Everyone opposed, no. Okay, the ayes have it. Who'll be carrying that in the House for you, Senator?
I'll leave that up to the wisdom of the chairperson.
Do we have a okay, we'll work on that then.
Right.
Thank you.
Thank you very much.
Okay. Yeah. Because I want to talk to some people. No, Senator Albers, sorry. We're deciding whether you're a senator or a representative. We're demoting you. No, sorry.
We are Senator.
Thanks.
To my friends.
Senate Bill 358 for members of the committee. Senator Albers, welcome.
Thank you, Mr. Chairman, distinguished members of the committee. I have a bill that's small in content but big on the results of helping our children. To give a slight bit of background here, I worked with several folks and organizations throughout the country, including Rotary International. I'm a Rotarian, as many of us are in the General Assembly, and continuing the efforts that have been championed by many of you on this committee, as well as our chair in the Senate, Chairman Unterman, in an effort to stop human trafficking. We have found that oftentimes those in foster care, when they have been missing or they are runaways, they end up in human trafficking, and we're always looking at ways of fixing that process. This bill, Senate Bill 358, makes a very minor tweak that when we report children that are missing, it will capture all those folks. And I will specifically guide you to lines 11 and 12, where we're adding the words caretaker, governmental unit responsible for the child, or other person with legal custody of the child, which adds to the current language of parent and guardian. The purpose for this is if a child is in foster care, or someone who is in foster care is also watching them, such as an aunt, an uncle, a grandparent, or they're in state care, that if they are reported missing, that immediately gets notified to the police. Now, we have a great system in Georgia. When children are reported missing or runaway, that we have a great network, and we know that the quicker they're reported, there's a better opportunity of bringing those children home safely. The longer that time elapses, the percentage goes down of bringing them home safe. So this bill will seek to do just that, to get them reported quicker so we can bring them home safe and sound. And I'll yield to any questions that you may have.
Thank you, Senator. Any questions from members of the committee? Seeing none, what is the pleasure of the committee? Representative Morgan.
Thank you, Mr. Chair. Senator Albers, thank you for this bill. I served on the commission to work on this issue, and so I'm very happy that we're continuing to strengthen our laws. And so with that said, I move due pass of Senate Bill 358.
Motion due pass. Do I hear a second? Any discussion? All those in favor signify by saying aye.
Aye.
Those opposed, like sign. Senator, thank you so much. And can, if I may ask you, who you going to get to carry the bill for you?
My friend and fellow Rotarian and personal representative, Harry Geisinger.
All right. Do you have anyone else? That's a joke. That's.
I
a
defer
little
to the
levity.
chair's wisdom.
Thank you.
Thank you all very much. Appreciate it.
That's a safe bet. That's a pari-mutuel kind of bet joke. All right, got to explain the humor. Got to explain the humor. You're in trouble. All right, who's the next victim? Senator Stone available? All right, to represent Chairman Martin, Senate Bill 268. If you would, Mr. Chairman, just because I know there's been some late changes, if you'll reference us a number.
Yes, sir. Mr. Chairman, I'm bringing this today of a substitute that is LC 335628 ERS.
Everybody got that? Great. Proceed, please.
If it,
I'm sorry. I'm sorry. Yes, ma'am.
Senate Bill.
Yes, ma'am. Yes, ma'am. It was added later. Last minute changes. Any other questions? All right, let's see. Do we have copies of ERS, Senate Bill 268? Give us just a second, Mr. Chairman. No. Anyone else? Thank you. Proceed, Mr. Chairman.
Thank you, Chairman Rogers. Members of the committee, I bring to you today, on behalf of Senator Chuck Hostetler, substitute to Senate Bill 268. It's very simple. I mean, we hear that all the time around here, but it doesn't get any simpler than this is on lines 11 through 16 of the code. This just, I can read it, but everyone else can. This just says a hospital who is in agreement with or leased from or operated under agreement with a hospital authority can't, when they refer a patient from one entity that they own to another one, they have to tell the patient that they own, they have an ownership interest in both interests, and that the patient has an opportunity to look at other places for treatment. It's just information to the patient. I can give anecdotal information where my mom was recently under care, and her oncology practice was acquired by a hospital. She had no idea. She went in. Things were different. Now, everything's worked out fine. I don't want to represent to this committee that my mom was treated in any way unfairly or charged anything that she wouldn't have been charged. But when somebody is having treatment and things like that change, until you've walked in those shoes and know how fragile you can be, walking in and finding out there's a change after you walk through the door is just a little disconcerting to folks. So I would ask the committee to look at this language as a positive for patient information, and simply that, providing the patient's information about the ownership of the various facilities so that patients can make informed decisions for their care between them, their families, and their physicians. Answer any questions, Mr. Chairman.
And Representative Henson.
Thank you. Will the gentleman yield?
Yes, ma'am.
In a situation such as DeKalb County, if you were to present a DeKalb Medical at Hillendale, and for some reason they felt it was necessary to transfer you to the other, because for some reason or other, either they needed bed space or they had something else that they're able to do, that they have to tell you that they, I mean, beside the fact that the name's the same, do they have to tell you that they have a partial interest and so forth?
Well, yes, ma'am. This is, I mean, if you read, the per se language on line 11, no patient may be referred to an entity which a hospital has an economic interest. So if you were at a doctor's office and they're referring you to another specialist, that the hospital also had an interest, the patient would have to be advised of that and advised that they have opportunities to seek care in other places.
I don't think that answered my question.
Well,
Very specific. If a hospital has more than one facility, Piedmont has several different facilities, Emory does, so does DeKalb Medical. If you're, for some reason, being referred from one hospital to another hospital that's under the same name, same ownership, and everything else, do you have to be advised?
I think if they are an entity that is owned by the hospital, I think you would be advised. I believe you would be covered. Yes, ma'am.
And is an exception made if a person is unconscious and they're being transferred from one emergency room to another?
I would yield to the committee here, but I don't think there's anything in this language and a lot of other places in this particular title that interferes with exigent care.
Okay, and then lastly, if one group of doctors is referring to another, that's sort of relying on the fact that every group of doctors knows when they do a referral that this other group might be owned by the hospital or by some other part. Okay, if you're being referred from a primary physician to a specialist and they're both owned by the hospital, you're assuming that the doctor or the front desk or whoever knows that the practice they're referring to is also owned by the hospital.
I think in this day and age, yes, ma'am, I think that's a fairly good assumption. I think most entities that are owned by a hospital realize that they're part of a larger network. In fact, they market themselves that way.
Right. Thank you, Representative Henson. Representative Clark.
Thank you, Chairman. Representative Martin, thank you for bringing this bill. It looks, I like the idea behind it, but I do have a question for you. So what happens if I call my doctor and I'm talking to him over the phone and he gives me a referral? Or for instance, I was at the ballpark the other day and I asked for a referral. I thought maybe up to 5 children, it might be time to get a vasectomy here. So
okay, that's a little bit more information we needed. He saved that line for you, Madam Chair.
Hypothetically.
Oh, you haven't learned your lesson yet?
So no, not really hypothetically. Anyhow, I got me 5 blessings, and so I asked him for a referral, who he'd recommend, and he gave a referral. How does that work?
I'm sorry, Representative Clark.
No, I mean, does he have to give me a written disclosure that he has an interest in Northeast Georgia? That he. I'm not sure that I understand. Like, if I call up and I ask for a referral for a specialist, he has to give me a written disclosure that they have an interest in.
To be honest, Representative Clark, I don't know the plain definition of patient to me. You just calling and you're not under the care of that doctor and asking them for a referral, I don't know that would create a patient relationship. I yield to some more people that know. But if you were a patient, I think if they referred you to another entity to which the hospital that they were part of had an interest, I think they would be required to give you notice.
Okay.
And if I might further, I don't think that's a bad thing, because I think it's very important for people to understand that they have opportunities to seek service in other places.
Thank you for answering the question. Again, I like the idea of it. I just had that practical question of how would that work out.
And thank you for the light moment. I needed that given the rest of the day.
Pardon.
Thanks, Mr. Chairman. And Mr. Chairman, I was just wondering, I'm a little hesitant to always just give more forms for patients to have to fill out and sign and to read. I know even the protected health information forms and the privacy forms now. If the patient ever reads one, it's terribly confusing. But I'm wondering if within the same ownership of hospitals, if it might help the continuity of care, because the physician referring from one to another group that's in his group maybe might be a little better care. And do we want to scare people by saying you don't really have to do this, but we own the other one and create some maybe suspicion in the mind of the patient?
If I may, Representative, I don't think anyone is trying to say in this language. It's fairly simple. It's just letting the patient know that there's an economic interest held by the referring party to the referred party. I think that is important. I won't go back, but I think 20-some years ago in Georgia, there was a fairly large case about, some physicians in certain places referring people to certain infusion centers that they had ownership and interest in. I think that turned into quite a federal mess. I'm not at all suggesting that people that do that here are doing that, but I do think it is important, and from personal experience, with a family member who is under treatment, in a stressful situation, I think it's important for them to have all the information. Just the very fact in the very fact pattern that I mentioned earlier in regards to my mom, it was just disconcerting for her to get there and realize that the practice had been purchased and things had been changed, and she did not know. Had she known, there wasn't a beat missed. The doctors at that practice did a fine job. She's doing well, and we're real happy about that. So I think what we're trying to do here is simply let people know that those that are referring them are, have an interest in the party to which they're being referred. And I would offer that by knowing that, it puts it right out there on the table, and they're saying, I'm referring you to Representative Hardin's practice, and we're in business together, and he's still the right person to go, but you can go to Representative Barr if you'd like to. And I think that in all patient situations, providing that information, in my opinion, would be advantageous for the patient. I think it would also, in the long term, be advantageous for both the referring physician and the people that are receiving the referral.
Okay. Thank you, Mr. Chairman.
Thank you, Representative Hardin. Representative Pack.
Thank you, Mr. Chairman. What happens if they don't disclose this financial interest? And what are the penalties?
We're going to send them to Representative Clark's doctor for whatever percent. Now, Representative Pack, that is a good question. I think that there probably throughout this title, numbers of things where you are to do certain things. I would suspect that a complaint could be made, and there are the proper boards to hear that against any physician. But I mean, this doesn't create. You're an attorney, sir, and I'm not. But I don't think this creates any sort of a criminal liability or perhaps even a civil one. It may create at least a rebuttable cause of action against a health board. But I would leave that to the more learned attorneys.
Thank you, Representative Kaiser.
Representative Martin, I might need a little more anecdotal explanation. I think I get the intent, but it feels really broad, somewhat vague, for a number of reasons. One is why are you only in this case talking about hospitals? What about physicians or say a community health clinic or a neighborhood clinic? I mean, because there's lots of places, there's lots of entities in the medical profession that have fiduciary interests, mutual interests.
I believe they tried to draw this narrowly. This was actually a bill that was discussed in the Senate, was passed up into Senate rules, and then it was not able to get out of Senate rules before crossover day. I think in the interest, the author and Senator Hosseller wasn't able to be over here today, so I'm presenting this for him. But I think in his interest, he has tried to narrow it down. That typically these are the hospitals that are in areas where a hospital is large, and over time, when we've seen in the last few years, hospitals have been buying more doctors' practices and ancillary medical facilities. So I think we were just trying to limit the scope to those hospitals that were in agreement with the hospital authority, so that people had knowledge of those referrals. The lady might, have a point that this information about referrals, about, if you will, co-owned entities, might be well served to be made broader.
Can I follow up, Mr. Chairman?
Yeah, please, if you promise to be fairly lengthy.
I'll be as lengthy as I can. I can talk slower if you'd like. I guess also one of my, and I'm not trying to grill you. I'm trying to wrap my mind around what still feels really kind of vague to me. So if you have a patient who goes, say, to the emergency room at Grady Hospital, and Grady has some kind of fiduciary interest, don't know what, but maybe with Atlanta Medical Center. And they don't, but if they did, I'm just trying to talk hypothetically. So if an emergency room nurse or physician says, we have no more emergency room doctors that can take care of this gunshot victim, but we know at Atlanta Medical Center they have some availability and they refer them there, would they have to give that patient something in writing indicating that they had some fiduciary interest in Atlanta Medical Center at that time of the referral?
Two things. I thank the lady for her question. I mean, two things, I guess. It's not a fiduciary interest. I mean, it specifically says an economic interest is what it says to another facility. But the second question, and, I would, call on the good Dr. Watson to help me if I'm incorrect stating this. I believe emergency accident situation would override anything else. I mean, if someone, is presenting with an emergency type situation, I don't believe one is limited. I think you get care first and ask, for lack of a better term, ask questions later. This is simply meant that if you're in a doctor's office and they're referring you for it could be an MRI type situation, that if they're referring you to one of those that's also owned by the hospital, that they let you know that we have an economic interest in that, so that you have another option to go for. It doesn't tell you that one is better than the other. There's no comment written there. It's just that we have not. And if you think about that in a business situation, many times somebody's a consultant, and if you and I were working on something, and you were a consultant for somebody else, and I said, Representative, if you had introduced me to them, we could work on something together and work a business deal. But if you're under contract with them, you need to let them know that you and I are in business too. That's just something that we do.
So I guess for me, the fiduciary and the economic interest feels like the same, and maybe that's why it feels vague to me. So I have a colleague who says she can help me out, but.
What they usually do is a case manager will get to this point where a patient has to be referred to another facility. Take something like hospice. The hospitals tend to have their own hospice facilities, and so what that case manager should do is ask that person, do you have a preference? If that person doesn't have a preference, then they move to make the referral to more than likely a facility that's connected to the hospital. And so it didn't say in the bill, but the only way I can see that this can clearly be done is that if another form is included in that exit package that can verify that the patient was informed of the connection between the two facilities. That's the only way I see that this can be
enforced.
Yeah, enforced. I don't know if that's was considered, but it happens all the time. But the first point a care manager should ask you, is there a place that because it could have been somewhere you used before, your family used before. Right. And after that, then they have the liberty to, and actually they're supposed to have a list for you to peruse through. That's the only way I can see how this can really be enforced. And
well, Representative Martin, do you know why the senator wasn't more specific? It's because I would be more comfortable with language like Representative Randall's talking about. This just feels real open-ended, but maybe I'm just not reading something. Maybe I'm missing something. Wouldn't be the first time.
Thank you, Representative Kynes. Chairman Pruitt.
Thank you, Mr. Chairman. To help the Representative Martin out a little bit, this language may have been taken out of another piece of legislation which the physicians are already required to do this. So this is relating to hospitals only. The physicians already have to make sure the patient is aware. when they're referring to another physician, that they have entities that they're a part of? My understanding is they already have to do this under law.
Oh, yes, sir, and I may have failed to understand Representative Couch. If a doctor is referring you to a place where he owns a part of a surgery center,
right,
he has to let you know that already. And what we're doing here is if that physician's practice is owned by a hospital and the hospital also owns a surgery center, we're just asking them to do that. So if I may, Mr. Chairman, to address Chairman Pruitt's point, there could have existed a situation where Dr. Pruitt and Dr. Martin owned a orthopedic practice, and if we had referred someone to a surgery center, we would have had to let them know.
That's
but
right.
in the time, if a hospital covered under this had bought both the surgery center and our practice, that notification would go away. We're just trying to make sure that notification continues.
Bringing the hospitals into the same compliance as doctors and physicians already have.
Yeah, thanks, Chairman Pruitt.
Thank you so much. Representative Watson.
Really, I was just going to follow up. Thank you, Mr. Chairman. I was just going to follow up on Representative Pruitt's comments, and but I have nothing further to add from that standpoint.
Thank you.
My question is this. So, referred. Usually in a hospital, that referral would come from a physician, right? I mean, to move. I'm trying to figure out who the referrer would be, I guess, is what I'm saying. Like, who?
Well, I mean, Representative Randall's comment, I think that could come from a referral or, as she said, a case manager.
Like if you were in the hospital, so there's a crisis situation.
The referral for the service itself comes from the physician.
Right.
But the choice of the
facility
will come from the case manager.
Well, not all physicians are employed by a hospital. So what becomes their responsibility? What becomes that independent physician who's in a hospital, who is part of a hospital authority? What is their responsibility? What is the monitoring effect on them for saying you need to go to the other side of town, or you need to go to this other doctor's office when you're in an emergency room? If you have a broken bone, sometimes they're X-rays, and then they're days later when you go back in to actually once the swelling's gone down. A strange practice when you're in pain, but that there are all kinds of ways that I can see are challenging for this.
Well, again, let me say this. I believe in exigent circumstances, you get the patient triaged properly into the place where they get the care without regard to a lot of notifications that are otherwise required. That when you talk about this. And remember, this is not talking about simply in a hospital referred to someone. This is an entity in which a hospital has an economic interest. A hospital that's covered under this could have an economic interest in in a doctor's office, in a surgery center, in an outpatient rehab facility. There's a number of medical procedures that could be covered by this, and it says when the entity, when they're referred from one of those entities to another, they have to be given written notice. I don't believe the doctor is going to stand there and give them written notice per se, but the facility itself would make sure that the written notice is given.
The facility. So who would excuse me? I'm sorry. Who would be that position? Who is that person if it's not that doctor?
Well, I mean, again, we're talking about an entity here, and each medical practice, each entity would be set up properly. That could be it could be the office manager, the nurse.
I understand in a doctor's office, but we're talking about a hospital authority. So that's where the confusion comes in to me. If they're in the hospital with an independent, a doctor who is just has ability to be there, is calling on his patient. I don't understand who would hand out. I guess in a lot of ways, who is responsible ultimately for handing in the hospital? I understand if you're in the doctor's office and you're one-on-one in that.
And that's fair. And fortunately or unfortunately, I've just gone through a series of this, and when we were discharged, you're handed a lot of notifications and paperwork about where you need to go to get your next visit, where you need to follow up for your sutures, where when you need to come back from this. And there's a number, and each one of those is sort of a prescriptive staff. And we actually had a case manager that came before my relative was discharged from the hospital and said, you need to do this to check on this, and this for home health care, and this to go see this service. And I think what we're talking about here is if you were in a situation where you're in a hospital that was covered by this and they were referring you to entities that they own, just part of that paperwork is going to be that these several entities are owned by us. You don't have to use this. I mean, the home health care that was assigned in this particular case may or may not have been owned by the hospital that was involved here. But if it were, they would be required to let you know that this home health care provider is owned by us. We have an economic interest. You can use them, or you can get the same service from someone else.
In home health care, in hospice, and things like that, where there's sometimes a little bit of time to sort of think through it. But sometimes in a hospital, it's more of a of a crisis situation. So I'm just trying to figure out who in that hospital setting needs to make sure that all the T's are crossed and the I's are dotted. I guess what I'm saying. Who ultimately becomes responsible for that? Because that's kind of like the hospital. Suddenly you have a patient, you have a physician, and you've got a hospital trying to figure out what to do.
Yes, ma'am, and I think we get into that here. We just tell them the notification needs to be done. I don't believe it's ours. I mean, it may be yours as a committee, but it's certainly not mine to tell them exactly who I want to hand that paperwork. We want the notification to be given to the patient so the patient has an informed idea of what's going on. But I don't think this committee can tell each individual entity that may or may not be owned by these hospitals, it should be the office manager, it should be the nurse, it should be the case manager. Each individual facility is going to develop policies and procedures to do that, just like the doctors do today.
All right, thank you. Representative Hawkins.
Let me ask you a question here. I'm a little confused, but not really. This was Senate Bill 268 that really addressed, in the committee, the delegation of scheduling of drugs of physician assistants. It was substituted 5579 ERS in committee, and it still addressed that same issue. But as it hits the Senate floor and is substituted on the floor, we got a whole different bill here. And this bill has not really been vented. Yeah, I'm looking at it. This bill has not been vented by any committee other than this one, and we're being asked to vent the bill right now. Is that correct?
Well, yes, sir. You just said Senate floor, so I'm confused. This did not go to the Senate floor. I thought I made that clear earlier. This language passed out of Senate committee.
This language did?
Actually, a more intense language than this passed out of the city. This is
what number bill was that then?
I don't have the number, sir.
Okay, because it's not 268.
No, sir, it was not. I
can,
get the senator to let you know what that was.
Okay.
Representative Henson.
You keep referring to this as hospitals, hospitals, hospitals. Does this apply to all hospitals?
It applies to hospitals that have an agreement with the hospital authority.
So therefore, it has to tie into hospital authorities. But how many different hospital authorities do we have in the state of Georgia?
I do not know, ma'am.
That's going to be very confusing. If you're at practice, then you just happen to be a doctor that works for a practice and you're trying to do your business, and you know that you're affiliated with the hospital, and you just don't really know all the dynamics because people, practices hire other doctors. It's not just the principals that are involved, they hire other doctors. So what you're really doing is expecting every single physician that works for a practice or might be working for 2 or 3 different practices to know everything about the practice they're working for, and if they're referring to some place, then they're supposed to know. I don't think, I'm sorry, I just don't understand, and I don't quite see the reasoning behind it. I mean, it might pertain to someone, it might be important to someone, but it's very broad and pertains to an awful lot of folks. And
thank you, Representative Henson.
If she has a question, I'll try to answer it. No, I mean,
we're gonna,
she made a good point. She didn't ask a question, I didn't have a response.
Thank you so much. We've got some people that would like to speak on the bill, and in the interest of time, I'm going to let you be as clear as you can possibly be, and we're going to start it off with Temple Sellers. You're welcome to sit right there, Mr. Chairman.
Thank
you. And Ms. Sellers, I'm going to just, please don't take my directness as anything but directness. You've heard all the questions, So if I start giving you one of these, that means that I kind of feel like it's going way overboard.
Okay, I appreciate that. My name is Temple Sellers, and I represent the Georgia Hospital Association, and I will be brief. I would like to begin by saying that this language is completely new. It hasn't passed out of any committee on the Senate side. We've been tracking, obviously, all the bills that are of interest to our members, and I can assure you we would have known had this language passed out of a committee or been heard in a committee. I think a lot of the confusion that I've heard stems from the fact that the bill does kind of confuse the role of hospitals and physicians, because there is in Georgia, as well as federal law, laws that require physicians to provide notice to patients before they refer a patient to a facility where they have, in Georgia it's called an investment interest. They have to give this written notice saying I have an investment interest. That's because physicians are the ones who refer patients. Hospitals don't refer patients. Even caseworkers don't actually refer patients. A patient referral is done by a healthcare provider. You're referring a patient to a facility to obtain services. And the problem here is that this isn't even limited to hospital employed physicians. So you could have a physician that's not employed by the hospital and wants to refer the patient from one facility, to another, and would then have to somehow contact the hospital and try to get the hospital to provide written notice to the patient before they could make the referral. It puts the physician in a very awkward position. It puts them in between it puts the hospital in between the patient and the physician relationship, and that creates a lot of concerns, obviously, just for patient care. There are a lot of exceptions also. This was mentioned, I think, there was a lot of concern about emergency services. Georgia's patient self-referral law that prohibits physicians from doing this has lots of exceptions. It has exceptions for emergency services. It has exceptions for services provided in rural communities. It has, a whole host of exceptions that are not present in this particular language that I think do raise some concerns as well.
Thank you so much, Ms. Temples, for sharing the position of GHA.
Thank you very much.
Brian Luby, you're on deck. Or you're up. Tim Kibler's on deck.
Mr. Chairman, members of the committee, Brian Luby with the Independent Physicians of Georgia. Appreciate your time this afternoon. The Independent Doctors of Georgia support the substitute to Senate Bill 268, and we think it's necessary because of the changes that are going on in health care. As has been mentioned under Georgia's patient self-referral law, physicians are required to give notice to patients when they refer a patient from an entity they have an economic interest in to another entity. However, with hospitals acquiring physician practices, and the physician no longer has an economic interest in the facility, and the hospitals are not subject to Georgia's self-referral law, the patients lose the benefit of having that information. Regarding some of the questions that have been raised, as been noted, Georgia does have a self-referral law that applies to physicians. Representative Pack had a question about enforcement. I believe the Department of Community Health's Division of Healthcare Facility Regulation would have jurisdiction over any healthcare facility that's licensed by them that violates state law, so they can impose sanctions pursuant to their authority to impose sanctions in Title 31. With regard to the hospital settings, the hospitals, pursuant to state regulations as well as CMS regulations, have to comply with very stringent discharge planning requirements, and that would be a perfect opportunity for the hospitals to comply with this law and provide the patients with notice. So we believe that this is very important, particularly given in light of the increased acquisitions of physician practices by hospitals, which kind of takes everybody out of the loop there, and the patients are left without the benefit of receiving the disclosures that are required under the self-referral laws. If you have any additional questions, I'll be happy to answer them. Otherwise, we would appreciate your favorable consideration.
Thank you, Mr. Luby.
Thank you.
Tim Kibler, good afternoon.
Thank you, Mr. Chairman. Tim Kibler with the Georgia Alliance of Community Hospitals. I'll try to be brief as well. We're very significantly opposed to this bill. We feel like it creates a burden on Georgia's public hospitals that won't be borne by other providers. And it's in many ways a very unique burden in that the hospital will be held responsible for the doctor's actions. As Ms. Sellers said, the doctors
are the ones that do referrals. So the hospital is going to have to inject itself somehow between the patient and the doctor to make sure that the doctor is in compliance with this. And I would think it's going to be, it will create many more challenges for doctors who are not employed, in my view, in the hospitals where they work, than it will do anything to help the patients. I'm afraid, frankly, it will interfere with care as much as it's likely to assist a patient in making decisions. The unspoken truth in this is that the patient is going to go where their insurance company pays for them to go, or where Medicaid or Medicare pay for them to go. So it's sort of an additional burden that pays no benefit really to the patient and will inject itself into the physician-patient relationship. And as Representative Henson, I think the point that she's trying to make is it will apply to DeKalb Medical, but not to Emory. It will apply to Savannah Memorial, but not to Candler St. Joe's. It will apply to Grady, but not to Piedmont, et cetera, et cetera, et cetera. It's setting two different standards by which hospitals are going to have to conduct themselves, and it will put the doctor, and I think it's unlikely to happen, but if a doctor wanted to harm a hospital, this would be an excellent vehicle for them to do that. Simply make a referral to a hospital-owned entity and not tell the hospital staff, the hospital administration, that referral had been made, and all of a sudden they're in violation, subject to potentially significant penalties from DCH, and the doctor potentially faces no penalties whatsoever.
Thank you.
Thank you very much.
All right, what is the will of the committee? At this time, I'll call on Representative Hawkins.
When I move to table this bill at this time.
I got a motion to table. I've got a second. Any other discussion? All in favor of the motion to table signify by saying aye. Aye. Those opposed, like sign. Substitute Senate Bill 268 has been tabled. Thank you.
Thank you, Mr. Chairman.
Thank you, Chairman Martin. All right, who's the next contestant? Senator Stone. Senate Bill 304, and I think there's been a late change. Am I right somewhere? They're passing out now. Staples are weird, but don't worry about it, I've been told. And Senator, if you'll give us just a second to get the members updated.
Right. Do you have that change? Okay, so they see that. Okay, good.
All right, does everyone have LC 371774S? That's what you'll be working off of, Senator?
That's correct, Mr. Chairman.
I think you may find where they're actually staped at the bottom. If that helps you. And you've also have got some information, Senate Bill 304, Continuing Care Retirement Communities Equity Model. And with that, Senator, if you'll proceed, thank you.
Thank you. This bill deals with community care retirement communities, or continuing care retirement communities, better known as CCRCs. These are developments that have usually three levels of care: independent living, personal care, and then nursing. They are usually a continuing spectrum of services. This bill allows for the CCRC industry to offer a product that is a new model based on buying into the facility. Usually it's an apartment or condominium at the independent living stage. This was something that the CCRC law implied could be done, but the insurance department felt that it would be better to have it clarified in statute that CCRC developers could offer an equity model. Normally, CCRCs, you pay upfront money to guarantee a spot, and you rent the apartment when you're in the independent care level, and then you transition on to the other two stages of care. As passed in the Senate, there was a sunset provision that was due to some negotiation within the industry. This has been deleted from the current LC, and there have been proposed changes on line 32 on page 2 where there are deletions of but not dedication and beds and inserted services. With that, I'll be happy to attempt to answer questions. I have Kevin Isaacson and Tom Bauer here who are very familiar with the industry and the need for this bill and what it does.
Thank you, Senator. Any questions from members of the committee? Let's go with Chairman Rogers.
Yeah, I do have a question. The insurance department's in charge of licensing, financial solvency. How often do they audit these independent living facilities?
I'm not sure. Mr. Bauer may be able to help.
I believe I can answer that. They have to do it, I think, every 3 years now.
We changed that to 5 years.
You may be more familiar with Mr. Rogers. DOI, everybody they regulate there is a period of time by which they have to be audited.
But they can audit anytime they want to.
Absolutely.
Okay.
And in fact, the current law that doesn't appear in here calls for a very constant monitoring because there are reserve finances that have to be in place.
So they report each quarter to the department. Is that how they do it?
It would be more annually, I believe.
Okay.
All right, thank you, Mr. Chairman. Any other questions? Representative Pruitt. Chairman Pruitt.
Thank you, Mr. Chairman. On line 60 and 61, it says code section 31-7-12.2, and then over on line 97, it refers to the same code. Are we changing code sections and definitions in any way?
Mr. Chairman, may I answer that? No, sir. You may remember that actually it was about simultaneous with the updating of the CCRC code 4 years ago that the General Assembly passed a new level called assisted living community.
I'm very familiar.
Yeah, I knew you would be. And so this is a reference that it's just showing that that's another component of independent lodging that it is not.
Okay, thank you.
All right, if we may, I'd like to turn the members' attention to a small technical error right before I ask for your favorable approval. Anybody miss that? Just make sure. We're going to correct the error. On line 31, we have scratched out inadvertently due to an aggressive, the first three words on line 31, including such services. Okay, that should not be scratched out or crossed out. And instead, the first three words of line 32 should be crossed out, but not dedication.
We've got a 774. I think it's probably correct. You need to use
Excuse me, just a second. Just a second.
No, I know, but
LC 371774S. Does everybody? That's fine.
I just want to make sure he knows beds are at services.
All right. Again, for the benefit of members of the committee, it's just very small, scratched out the first three words of line 31, and it should have been where the first three words of line 32 were scratched out.
Correct.
It's the equivalent of a human typo. It happens.
Mr. Chairman?
Yes.
May I ask you to read the rest of that just to make sure, because there was a little bit more of a change than scratching those three words out.
Specifically, I'm assuming you're referencing line 32?
Yes, sir.
Then it would read, of such services to an individual not related by whatever that word is.
Very good. Thank you.
That's a nice try to trick me on that South Georgia accent on that word. You're talking about it's away, not your way. And with that, I'm going to call on Representative Hawkins.
I move due pass.
Move due pass with the human typo. Second, Representative Harden. All those in favor signify by saying aye. Aye. Those opposed, like sign. Pardon me? The ayes clearly have it.
Thank you, Mr. Chairman.
Thank you. And I think that's all we have today. Well, let me look.
Yeah, glad it worked out.
Well, hold on. You want to go again? Don't want to ask them what?
Senator, thank you very much. 3 or 4 copies and make sure none of them have the red 01 on them.
All right, listen. Can I get the committee members' attention, please? I'm sorry, Representative Morgan. Would you like to be recognized? I apologize for that. I'm sitting too far away from that. And I appreciate your due diligence.
I think on the back side of it, see the gray button on the back side of your microphone.
Hello, testing. So, Mr. Chairman, I had my button pressed because I'm confused. I had a procedural question. We were given a bill that was a substitute in our folder, then given another bill that was a substitute of the substitute right before the bill was called up. We were asked to accept changes, but it was not done through a motion. And then when a question was called, it was not clear as to whether or not we were voting on the changes or the bill itself. And so I'm just trying to understand what just happened.
Yes, ma'am, and I thank you so much, Representative Morgan. You know me that occasionally I just get so excited, and that's a procedural error on my part, and I ask for your forgiveness, as well as the rest of the committee. We just passed a bill with those changes, and procedurally I should have done it a little differently. Representative Morgan, does that help at all? Yeah, okay, let's do that then. Let's go ahead and reconsider. Thank you. We're back in recess. Back in adjournment. There we go. Let's reconsider the action. Representative Hawkins, restate the motion.
I move to accept the changes on lines 31 and 32 as stated by the chair.
We got a motion to accept the changes of the human typo as we described it. As amended. Any second on that? Got a second. Any discussion? Thank you. Representative Morgan, would you like to be Representative Kaiser?
Thank you, Mr. Chairman. I just wanted to ask if Mr. Bauer wouldn't mind just explaining exactly what we're doing, because we're striking beds and putting in services.
Yes.
So what changes, and when we're striking including such services,
Well, yes, ma'am.
we're leaving that in, but we're striking but not dedication, and we're leaving in services and striking beds. So tell us just exactly what we're doing.
Without belaboring the point, there was some language brought to us this morning that some people thought was necessarily and some people thought might not be needed to be added to it. And so as we discussed it, I asked that the language that referred to dedication of beds be stricken, because later on in the bill on page lines, I believe they were lines 116 through 124 on page 4, part of that language very clearly asks that these changes not affect the current CON laws. That was language that the Georgia Healthcare Association asked for, and I was a little fearful that the dedication of bed would raise some kind of CON issue.
Does that have a certain
and there are other services beside nursing those beds.
Yeah. Okay. That makes sense.
Thank you for that. We have a motion now. Motion do pass. Second, as amended. Second, thank you, Mr. Chairman Rogers. All those in favor signify by saying aye. Aye. Those opposed, like sign. Thank you so much for your indulgence.
Thank you.
Has anybody got the bill with the S number on the back? There's a couple lucky prize winners out there. If you would give it back to the assistant over here. And Senator Albers, Senator Stone, excuse me. Who's going to be carrying this in the House? Representative Hawkins. Very good. Thank you.
Wait. Sign right there.